Hello, MedSurg students. This presentation is going to focus on the biliary tree. The biliary system, or otherwise known as the biliary tree, comprises of the accessory organs of the GI system. And those organs are the gallbladder, the pancreas, and the liver. These organs secrete enzymes that help us digest food, so they're instrumental in ensuring we have adequate nutrition. The gallbladder is a pear-shaped organ that holds 50 mLs of bile for us to use PRN. Bile is used to digest fat. So after we eat a fatty meal, the gallbladder is going to start contracting. And when it starts contracting, the bile flows into the cystic duct. The cystic duct meets the common hepatic duct and it becomes the common bile duct. So the bile flow goes from the cystic duct to the common bile duct, and it's going to enter the duodenum via the ampulla of Varda. Okay, there are 4 terms I need you to know, and they're listed here in order of severity. So the first term is cholelithiasis, and if you recall, lithiasis means stone, chole means gallbladder. So this refers to gallstones. The second term is cholecystitis, which means inflammation of the gallbladder. The third term means choledocholithiasis, which means a stone is in the common bile duct, which can lead to cholangitis, which is a life-threatening disorder if a stone is stuck in the common bile duct. That can happen. Cholecystitis, as I mentioned previously, is inflammation of the gallbladder wall. The most common cause of cholecystitis is cholelithiasis, which is, as I mentioned previously, is gallstones. However, gallstones don't always cause cholecystitis. You could have gallstones and never know about it, just find out about it on a random ultrasound that you have. And then cholecystitis could be with stones or without stones. And this term for stones is calculus. So acalculous means without stones. Okay, and that could occur when patients are in a position where they don't need to use bile. They have biliary stasis, such as people on long-term TPN use, people with high levels of estrogen, because that slows down peristalsis of the cystic duct, in people with sepsis or hypovolemia. Cholecystitis can also be acute or chronic, and we'll talk about both of them. The risk factors for cholecystitis can be easily remembered by the 6 F's. So they stand for fair, fat, 40, female, family, and fertile. And fair means Caucasian. So those are the characteristics of somebody that is going to be prone to cholecystitis. More risk factors for cholecystitis include eating a high-fat diet, having a sedentary lifestyle. Obesity is a risk factor for cholecystitis. Crohn's disease is also a risk factor. Any condition where you're starving your body, you could be at risk for cholecystitis. If you have rapid weight loss, that's another risk factor. People that go on ketone diets or lose a lot of weight really quickly, like on liquid protein diets, what that does is it stresses your liver to increase cholesterol. It makes more cholesterol. And high cholesterol has been also tied to cholecystitis. Gallstones are made of cholesterol, but scientists aren't sure what the tie is between high cholesterol and gallstones, but there is a correlation between those two. The signs and symptoms of cholecystitis include pain in the right upper quadrant with radiation to the shoulder, especially after eating a fatty meal, which makes sense because the gallbladder will start to contract after you eat a fatty meal, and so they can get biliary colic from that. The patient will have a temperature because it's an itis. There's inflammation. of the gallbladder. Nausea and vomiting are common. Dyspepsia is common. Eructication and flatulence. So eructication is belching. Flatulence, I think you know what that is. So air is coming out of both ends. Um, they'll have a positive Murphy sign and rebound tenderness. Murphy sign and rebound tenderness are elicited by providers because it's deeper palpation. And with Murphy sign, it's they have pain with deep inspiration during right subcostal palpation. So like right under the rib cage, and the provider presses while the patient takes deep inspiration. Rebound tenderness occurs when the provider actually they're doing deep palpation, but when they pull the pressure off of the palpation, that's when the patient feels the pain. That's called rebound tenderness. Biliary obstruction occurs in chronic cholecystitis and also choledocholithiasis. If you recall, I talked about it earlier. It refers to a gallstone being trapped in the common bile duct. When there is biliary obstruction, the flow of bile is obstructed. So the patient is going to become jaundiced. Remember, the liver makes the bile, the gallbladder stores it. In either event, the flow of bile is going to be obstructed. So therefore, the bile salts leak into the skin and cause yellowing of the skin and pruritus, like intense pruritus. Also icterus, which means yellowing of the sclera of the eye. Clay-colored stools, because bile gives our stools the brown color. Steatorrhea means fatty stools. They're foul-smelling and they float. They're floaters. And the urine is dark and foamy. It could look like beer, like a brown colored beer. And then pruritus I talked about. That's intense itching of the skin. With acute cholecystitis, you'll see a high white count. If the patient has biliary obstruction, you're going to see the other labs. Otherwise, if it's just acute cholecystitis, it's a high white count. If there is biliary obstruction, there's going to be a high bilirubin, because the bile can't flow. There'll be high amylase and lipase only if the pancreas is involved. And biliary obstruction with gallstones is one of the most common reasons for people to develop pancreatitis. So amylase and lipase only when the pancreas is involved. High alkaline phosphate could be increased with biliary obstruction, and then high transaminases, the AST and the ALT, those are like the troponins of the liver. If the liver is stressed, you're going to have high levels of those liver enzymes. And most specifically, the alanine transaminase, I can hardly pronounce that, the ALT, that will be elevated if somebody does have a gallstone and they have pancreatitis. And so that's one of the factors you look at to determine the cause of pancreatitis. Diagnostic testing for cholecystitis involves a right upper quadrant ultrasound. That would be the first test because it's the least invasive. A HIDA scan may be done. This would be done in nuclear medicine. They inject a tracer, a radioactive tracer, into the vein, peripheral vein, and they watch it through the biliary tree. And it's used to evaluate like biliary obstruction or bile leaks. And then the MCRP is like an MRI of the biliary system. It does use a dye. It's not iodine based. It's called gadolinium. Anyways, you do have to watch for renal problems afterwards. So make sure you're checking the BUN and creatinine beforehand, holding metformin beforehand, just like you would for contrast dye with the CT. Treatment for acute cholecystitis can involve doing nothing, sending the patient home if they come to the ED with pain, and explaining they need to go on a low-fat diet, encourage weight loss. Patients can take bile-dissolving medications. Opioids, especially if it's acute and they have severe biliary colic, you would give opioids, and ketorolac is another option. That's an NSAID. ESWL, we talked about that with nephrolithiasis, so same nursing interventions. And of course, surgery, the most common surgery is the lap chole. One treatment for cholecystitis is a laparoscopic cholecystectomy. They're really common. When I lived in Cobb County, Georgia, we did these all the time. I am surprised there's anybody living in Cobb County, Georgia with a gallbladder still. We did so many of these. It's a minimally invasive surgery. And if you look at this picture here, I've got these little laparoscopic dressings, little 2x2s with tegaderm over them. And there's one in the umbilicus. And these are where the surgeon puts the trocars in to do the surgery. You do still need to medicate for turn, cough, and deep breathe, because if you look here, the gallbladder is in an area where when you're breathing, it's going to cause pain. So make sure you medicate them so they will turn, cough, deep breathe, and use the incentive spirometer. After this surgery, it's common to get pain in the shoulder or thorax, and the reason is because they inject the abdominal cavity with gas so that the surgeon can see what they're doing inside the abdomen. So the best thing when they complain about shoulder and thorax pain is for the patient to ambulate. So encourage them to get up and ambulate. They can usually bathe or shower right after surgery. They can usually resume activities within a week, and they should eat a low-fat diet and introduce fatty foods one at a time. I had a surgeon that was really strict, and they couldn't drink carbonated beverages after surgery for like a week until they went and saw him, and they couldn't use straws because, those carbonated beverages and straws can cause gas. And after surgery, the best thing to know that the bowels are working again or that peristalsis has returned is that flatulence is occurring. The open cholecystectomy is not performed that commonly anymore. When I first came into practice, this was the only option if somebody needed gallbladder removal. And now it's reserved for people that have severe biliary obstruction, like due to cancer or chronic disease. Patients are given prophylactic antibiotics. They will have a JP drain after this type of surgery. It's going to drain serosanguinous fluid, which you would expect with JPs after surgery. However, for an open cholecystectomy, it may be bile stained for the first 24 hours, the drainage. The patient may need a T-tube, and I'm going to show you what that looks like. It's common to need a T-tube when they do common bile duct explorations. When the dressing is going to be on the right upper quadrant. And so when you're checking your patient for bleeding, don't just check the dressing. Make sure you're turning patients over to the side because blood can drip down the side of the dressing on the patient's side and you won't even notice it. And they could be laying in a pool of blood. So make sure you always turn patients to assess for bleeding after surgery. And make sure they're medicated because they definitely do not like coughing and deep breathing because the incision is in the right upper quadrant. This is a picture of a T-tube, and it got its name because it looks like a capital T. The capital T part is put into the common bile duct during surgery, so that bile will still flow, and it will flow out into a drainage collection bag after surgery. So it's going to remain in place until the edema subsides. I remember some of these staying in for like 9 days after surgery. Patients were in the hospital that long. You need to monitor the drainage closely and make sure that the T-tube is not kinked in any way because it can easily get kinked when the patient is sleeping, etc. Expect about 500 to 1,000 milliliters per day. It drains bile, so that color is golden to dark green. Monitor for the return of brown stools and monitor for peritonitis. Remember peritonitis, I talked about it in the renal lecture when I talked about peritoneal dialysis. So you're looking for a high white count, a board-like abdomen, and guarding because it's very painful. The next condition we're going to talk about is acute pancreatitis, which is life-threatening inflammation of the pancreas. It's caused by premature activation of excessive pancreatic enzymes that results in autodigestion and fibrosis of the pancreas. So, as I mentioned, acute pancreatitis is characterized by early release of digestive enzymes from the pancreas. The two most common causes are alcohol abuse, so it could be binge drinking or alcoholism, or biliary obstruction. With biliary obstruction, you'll see an increase in the AST and the ALT, and that's a key point because that differentiates biliary obstruction as the cause versus other causes. There's like a list a mile long of conditions that can cause pancreatitis, acute pancreatitis. So anyways, with the autodigestion, the patient could develop shock, DIC, which is a condition of clotting and bleeding and clotting and bleeding, and you'll learn about it in mother baby. Adult respiratory distress syndrome can occur due to pancreatitis because it causes a systemic reaction. Locally, it causes severe pain, and they can have hemorrhage in the area, and peritonitis can occur. So remember that board-like abdomen, high WBC, and guarding abdomen, and hypovolemic shock may also occur. Pain in acute pancreatitis can be quite painful. It could be very intense. So it's usually in the mid-epigastric or left upper quadrant area. The pain is sudden and radiates to the back, left flank, and left shoulder. It's described as continuous, although it does wax and wane. So you expect it to get better and you expect it to get worse, okay? It's very intense and boring means patients describe it as ripping through their body, right? Your patient is going to be guarding for the pain. We discuss patients with pancreatitis having intense pain. So to relieve that pain, patients need to remain NPO and they need to maintain bed rest. The reason is because when you eat or if you're up and moving around, it increases your metabolism and it's going to result in more digestive enzymes being released from the pancreas. And we don't want that, right? The pain is going to be worse by laying flat or being supine. The fetal position provides a lot of comfort. Bending the knees really helps. So that's also called the left lateral decubitus knee bent position. They can also sit upright and lean forward a little bit, and that will also help with the pain. Now expect that pain to wax and wane. It may get worse. It may start to feel better. There are a lot of other complications that happen with pancreatitis, like they can get pleural effusions, they can have respiratory problems. So make sure you always maintain A, B, C, D, E before you take care of pain. But it is really important to take care of pain. We talked about acute pain and acute pancreatitis. The other expected findings include weight loss, nausea and vomiting. Cullen sign is bruising around the umbilicus, and gray Turner sign, sometimes that's shortened to Turner sign, is bruising on the flanks, and they indicate intraperitoneal and retroperitoneal seepage of blood-stained exudates. Paralytic ileus can happen. They may not have a paralytic ileus, so if you don't hear bowel sounds, you may have to put in an NG tube if they do have an ileus. So of course, ask about flatus, passing flatus. And they could, if they have an obstruction, a biliary obstruction, they could become jaundice. Fruity breath and warm, moist skin could happen because of hyperglycemia. Now remember that the pancreas also has an endocrine function of secreting insulin. So you may expect hyperglycemia in a case of acute pancreatitis even if the patient is not diabetic. The pancreatic enzymes, when they're autodigesting the pancreas, cause fat necroses, and these release free fatty acids, which then bind to calcium. Okay, so this means that patients with acute pancreatitis are going to have hypocalcemia. So watch out for the signs and symptoms. We talked about them last semester in MedSurg 1, but remember cats go numb, so you're looking for convulsions or seizures, arrhythmias, tetany, spasm, stridor, circumoral numbness and tingling, and also numbness in the fingers. Remember the positive Chvostek sign, that's when you tap the cheek, and Trousseau sign. So those are some assessment findings you're looking for. Remember the order of abdominal assessment. I went into detail in the A&P in assessment lecture. For somebody with acute ascites, you are going to inspect. You're looking for that gray Turner sign or the Cullen sign. Auscultate vowel sounds because they may develop a paralytic ileus. If they're passing flatus, they won't need an NG tube, but if they don't have vowel sounds and they do have a paralytic ileus, they will need an NG tube. Percussion, because of pancreatic ascites, percussion sound will be dull. And in terms of palpation, remember nurses only do light palpation, but the patient abdomen may be rigid and very tender and guarding, so they may have peritonitis. Okay, the expected laboratory findings are the findings you'll see in somebody with acute pancreatitis. I talked about amylase and lipase in the assessment lecture. And so basically, amylase and lipase are enzymes that are released prematurely from the pancreas due to pancreatitis. Okay, so the amylase is going to increase first, and that increases within 12 to 24 hours of pancreatitis, and it remains elevated for 2 to 3 days. The lipase is actually more sensitive. It increases a little bit later, but it stays elevated for about a week. Alkaline phosphate, bilirubin, ALT, those are all elevated due to biliary obstruction, and I've talked about them earlier. The white count will be elevated because it's inflammation. The BUN will be high because of hemoconcentration. Glucose could be high due to beta cell injury. Inflammatory markers are high. Magnesium will be low due to fat necrosis. Same with calcium. Albumin will be low because of third spacing. And prealbumin is the most sensitive indicator of malnutrition, short-term malnutrition. So if your patient comes in and they haven't been eating for a couple of days, they're going to have a low prealbumin. So that's a good test to look at as well. Nursing care involved in acute pancreatitis. You want to collect data on the respiratory system every 4 hours because patients with acute pancreatitis are going to be prone to a left pleural effusion. That has to do with the proximity to the pancreas with the left lung. And with this pleural effusion, they can get hypoxic. They can also develop atelectasis and then pneumonia. So that's why you're going to watch the respiratory status carefully, and that's going to be a priority. Of course, if they do have hypoxia, you're going to use oxygen PRN. The next thing we have to worry about is circulation, because patients with acute pancreatitis can sequester up to 6 liters of fluid, meaning 6 liters of fluid have third space and is not in the vascular system anymore. Okay, so they're going to need 2 large bore IVs, and you would do this for anybody you were worried about they were going to have hypovolemic shock. So 2 large bore IVs, so 2 18s, which are the green IVs, green colored IVs. Okay, so you're going to do fluid resuscitation. So that means you're giving large amounts of fluid to prevent the patient from getting hypovolemic shock. Hypovolemic shock, the first sign is going to be tachycardia, then tachypnea, and then finally hypotension. Hypotension happens later than tachycardia. You want to control pain, and we've talked about this before, so keeping the patient NPO and on bed rest to decrease metabolism. Um, they're going to need a PCA pump, and they'll need antiemetics, a nasogastric tube, PRM. We talked about if they don't have bowel sounds, they're not passing flatus, they haven't had a BM, or they have severe vomiting, they're going to need an NG tube. Monitor for hypocalcemia. We talked about this earlier, that they can be prone to hypocalcemia. When the patient enters the healing phase, the diet changes a little bit. They're going to need small, frequent meals and snacks, moderate to high carbohydrate diet with high protein and low fat. Low fat is the important thing because fat really stimulates the pancreas. Supplemental protein shakes. Food should be bland with little spice. Avoid alcohol. Avoid caffeine. So remember, Coca-Cola has caffeine in it. Low fat and no smoking. Smoking increases your metabolism, so absolutely no smoking in acute pancreatitis. After repeated bouts of acute pancreatitis, the patient may develop chronic pancreatitis. This is usually due to alcoholism. The patient would develop diabetes type 1, which you know is unusual in adults, and this is due to chronic beta cell destruction. So they're going to need insulin, monitoring of blood sugars. So monitor patients with even acute pancreatitis. You would monitor them for the 3 Ps, check blood sugars frequently, but you also do it with chronic pancreatitis. They're also going to be prone to malnutrition because they can't absorb food, and you'll see that with weight loss and also muscle wasting. They will have steatorrhea, so they have those symptoms of biliary obstruction. So steatorrhea, jaundice, pruritus, dark foamy urine. So those are the signs and symptoms of chronic pancreatitis. Let's talk about PERT therapy. That stands for pancreatic enzyme replacement therapy. And usually it's reserved for chronic pancreatitis clients, but however, it can be used. ATI doesn't differentiate, can be used for acute pancreatitis. If they're having a lot of steatorrhea, you should see an improvement in the amount of steatorrhea if the patient is on PERT therapy. So you need to teach all patients not to chew or crush enteric-coated preparations. They need to take it with all meals and snacks, and then they need to drink a full glass of water after they take it. Administer the enzymes after an antacid or H2 blocker because it decreases pH and activates the drug. If the client can't chew, pierce a hole in the gelatin casing and place the contents in applesauce. You don't want to sprinkle on protein-containing foods. Wipe the lips after because the enzymes are going to cause skin irritation. And then instruct the patient to follow up on labs because it may increase the uric acid in the body. And to evaluate the effectiveness, look for a decrease in the amount of steatorrhea. To recap, the diet is going to be eat bland, low fat, high protein, moderate high carb meal, minimal to no spices. Eat small meals frequently and eat high calorie snacks. They may need protein drink supplementation. Avoid anything that makes the pain worse, such as caffeinated beverages, alcohol, high-fat foods. No nicotine or smoking, because that's going to increase the pain. Pancreatic enzymes, they have to take that with all meals and snacks and follow with a glass of water. Living area, if somebody's going home from acute pancreatitis or chronic pancreatitis from the hospital, ask about stairs in the house because they really need to be limited to one area. And they're going to need a bedside commode if they have steatorrhea. And then with what to report, you have to teach your patients to report an increase in frothy urine and fatty stools because that means biliary obstruction. Of course, if they have jaundice, they would report that too, and teach them about the 3 Ps of diabetes if they previously were not diagnosed with that. Okay, now we're going to talk about hepatitis. Hepatitis is inflammation of the liver that's caused by either a viral infection or maybe chemical toxins, most commonly viral infections. So that's what we're going to focus on today. Now, the danger with hepatitis, when we're talking about B and C, is that they can become chronic. When somebody gets chronic hepatitis, we're worried about them then getting cirrhosis and then getting liver cancer. Okay? So we really need to protect people from getting hepatitis by good health promotion and prevention efforts. Hepatitis C, there's a high prevalence in my age group, the over 60 age group. And the reason is when we were coming of age, sex safe wasn't the same as it is now. HIV hadn't emerged at that time, so we didn't worry about getting HIV at that time. So, really the only reason we were practicing safe sex is because we didn't want to get pregnant. So now, people my age, maybe they're divorced, maybe they never got married, whatever, don't have to worry about getting pregnant anymore. So they're not having safe sex. And that's why there's a rise of sexually transmitted infections among people my age. Okay, let's talk about hepatitis now. We're going to focus on A, B, and C. These are viral hepatitis types. Your book goes into D and E versions. I'm not going to go into that because D piggybacks on B, so it's the same thing. And E is transmitted the same way as hepatitis A. It's fecal oral. All right. So the incubation period is different for each one. For Hep A, it's 2 to 6 weeks. For Hep B, it's the longest. It's 6 to 24 weeks. So by the time somebody gets it, they may not even remember who they got it from, just saying. And then 5 to 10 weeks for Hep C. Now, the mode of transmission, you're definitely going to have to know that. For A, it's fecal oral, and I remember A is for anus. That's how I remember that. B, it's transmitted through blood or bodily fluids, so I remember blood and booty fluids. So, like through sexual contact or through, infected needles or infected blood products, sharing needles, I should say. And then C is the same as B, so that makes it easy, right? Examples of how the virus is transmitted. With A, it could be eating raw shellfish, not washing your hands after using the restroom. It could be spread through anal sexual activity and contaminated fruits or vegetables when you're traveling. Always drink bottled water. Never drink a drink with ice in it. And to prevent hepatitis A, good hand washing. You want to have safe sex. And for all of these with prevention, you don't need to refrain from social drinking, okay? Because when I get into if you get hepatitis, you can't drink for like more than a year, okay? So with hepatitis B, some examples, it could be transmitted through infected saliva or semen or vaginal fluids, but not through urine or feces, not through tears either. Organ transplants could transmit B and C as well. To prevent A, I talked about that. So to prevent B, Safe sex, sterile needles, needle precautions. They don't need to avoid alcohol unless it's excessive. Excessive alcohol could also result in inflammation of the liver. Some other comparisons involve vaccines. There are vaccines for hepatitis A and B, but not for C. Immunoglobulin, this provides passive immunity, and you can get it before you travel to a country that has a high prevalence, or if you're exposed, you can get immunoglobulin. So only A and B has immunoglobulin. If you get A or B, you will have lifelong immunity, but you have to remember that B and C can be chronic. Okay? So the risk of liver cancer is going to be increased in B and C. First, they'll develop cirrhosis, then liver cancer. So look for an elevation in the ALP. The good news is the expected findings in hepatitis are the same no matter which type of hepatitis somebody has. So typically the patient's going to complain of abdominal pain in the right upper quadrant, and that makes sense because that's where the liver is, and the liver is going to be extremely inflamed. So then they're going to be tender to palpation, even light palpation. They're going to have a fever because they have inflammation, nausea and vomiting, that's a GI sign, lethargy because they have inflammation of their liver, so they feel very tired. They don't feel good. They have malaise. It's like coming down almost like with the flu when they first have these symptoms. Arthralgia. Art refers to a joint, and algia refers to pain, so painful joints. And myalgia is painful muscles. Those are common signs and symptoms with all types of hepatitis. If there's biliary obstruction due to hepatitis, the patient is going to be jaundiced and have icterus. They'll have dark foamy urine, clay-colored or white stools. They'll have intense pruritus. I mean, so intense that they really scratch themselves silly, and they have excoriations. So you may have to put a pair of gloves on somebody that has intense pruritus, and make sure you're not using soap. Like you want to use a mild soap in tepid water, not hot water, when you're giving a daily bath. And they'll have elevated AST and ALT, the troponins of the liver, and ALP, alkaline phosphate, and bilirubin will also be high. And that's true in all biliary obstruction. They all have the same signs and symptoms. A patient may undergo a liver biopsy for any type of liver disease where they need to make a definitive diagnosis. It's the only way to make a definitive diagnosis of liver disease. So the implications for you are the patient needs to be MPO after midnight or 4 hours prior to a liver biopsy. Depends. In case they need to go to surgery, they need to be MPO. And then witness the informed consent and be present at the timeout. They're definitely going to need coagulation studies pre-procedure. The liver receives about 1,500 milliliters per minute of blood flow. So it's highly vascular is what I'm trying to say, and hemorrhagic shock is one of the complications of a liver biopsy. Okay? Instruct the patient to exhale and hold their breath for 10 seconds during the procedure when the provider needs to do the biopsy part. That's to prevent the patient from getting a pneumothorax. You should remember from MedSurg 1 that a neurothorax is when the lung collapses. So you're going to watch for those signs and symptoms after the procedure. So signs and symptoms of a pneumothorax include increased work or breathing, so increased respiratory rate, no, not being able to hear lung sounds on that side, dyspnea, persistent shoulder pain, and pleuritic chest pain. If you recall, pleuritic chest pain refers to pain with breathing. Usually it's on inspiration. Monitor for bleeding and signs of shock. The first sign you're going to see is tachycardia, increased respiratory rate. They'll be complaining of thirst and they'll have confusion, tachypnea, and a low BP. Remember, tachycardia is always first. You want to keep the patient on their right side post-procedure to enhance coagulation, okay? So in other words, your liver's on the right side. You're going to turn them on the right side to try to minimize bleeding. Okay, now we're going to talk about cirrhosis. And cirrhosis occurs over a number of years. There's extensive scarring in the liver caused by some kind of inflammation, and normal liver tissue is replaced with fibrotic tissue. And anytime an organ becomes fibrotic, it cannot function as it once did. Um, so the causes could be, the most common cause is actually hepatitis C in this country. It could be due to chronic alcohol use disorder. It could be due to chronic biliary obstruction or an infection. It could be caused by right-sided heart failure, which often is because somebody has COPD, or cor pulmonale, which is due to COPD. What that means is right-sided heart failure. So those are some of the reasons somebody can get cirrhosis. So expect people with cirrhosis to have fatigue and weakness, anorexia, which results in weight loss, dyspnea, because of where the liver is in their breathing, abdominal pain and distension, confusion, which I'll go into later, and emotional lability, which means press 1 minute, euphoric the next, okay? No telling what their mood's going to be like any time of the day. So those are some of the most early findings. Patients with cirrhosis develop portal hypertension. The portal vascular system is a venous system that takes blood from the small intestine and brings it back to the liver for like detoxification. So nutrient-rich blood. What happens is over time, when the liver becomes fibrotic, there is backup of blood in the portal system, and the patient develops what is known as portal hypertension. If you look at this picture here, you can see where the blood is backing up. So, for example, if you start at the top of the stomach here, this is the lower end of the esophagus, your patient can develop esophageal varices. Varices are very weak veins, and they can burst, okay? That's why your patient with cirrhosis needs to eat soft food. And then if you look at the spleen here, the blood can back up into the spleen. When blood backs up into the spleen, patients have what's called splenomegaly. When the spleen gets really big, it acts like a Pac-Man, and it ends up eating the red blood cells, the white blood cells, and the platelets. So the patient's going to have anemia, leukopenia, and thrombocytopenia. Okay, and then also on the abdomen, they'll have something called caput medusae, and it's basically a bunch of veins on the stomach that look like snakes. And I have a picture of that on the next slide. They also develop hemorrhoids, which bleed easy. So patients with portal hypertension, you have to worry about them bleeding. And then ascites is another condition that they can get due to portal hypertension. Here are some pictures of patients that have portal hypertension. These pictures demonstrate the physical findings you may see. The first picture is an anterior view of the abdomen, and you can see these snake-like veins. So that's why it's called caput medusae. And then the second picture is a picture of a man with ascites, and it looks like he's pregnant, right? This big pendulous abdomen. And if you know, the arm up here, only a little bit is showing, but the arm is showing muscle wasting. So it's typical for people with cirrhosis to have this big, huge belly, but yet their limbs are very thin due to muscle wasting. The bottom two pictures are pictures of bruising and purpura. And I talked in the previous slide how when the spleen gets really big, it starts eating thrombocytes. So that's one reason people with liver failure bleed. But the other reason is the liver manufactures coagulation factors. So if the liver is unable to do that anymore, the patient is going to be at high risk for bleeding. And their coagulation studies, the PT is going to be prolonged. So they'll need to have some vitamin K, or they may need fresh frozen plasma if they're bleeding. Ascites can be quite uncomfortable. If you remember when you were pregnant at the end, for those of you that have children, it was hard to breathe, right? Especially laying flat. Because of where the ascites is, they're also going to be prone to left pleural effusion, just like when I talked about in pancreatitis. So same signs and symptoms. To keep them comfortable, you can put them in, I call this the banana position. My daughter is a neuro ICU nurse and she calls it the taco position. So whichever one you like. Head of bed 30 with the feet elevated to help promote some draining of the edema in the legs, but also to help relieve their breathing difficulty. Measure the abdominal girth daily to see if the ascites is getting larger. Daily weights are a must to see if they're putting on fluid. And then low sodium diet to try to decrease ascites, and diuretics. And please make sure you're checking the electrolytes if they're on diuretics, and the BUN and creatinine, because at the end stage they will also develop renal disease. Paracentesis is a bedside procedure that can be done to relieve respiratory effort. So in other words, they take off fluid to reduce the ascites so that the patient can breathe better. Another reason they may want to do it is if they suspect that the patient has spontaneous bacterial peritonitis, which can happen because the liver, if you remember, synthesizes proteins, and one of those proteins are globulins, which help us with immunity and fighting infection. Also, because of the splenomegaly, the whites counts may be low, so the patient is going to be at risk for infection. Before the procedure, make sure the consent's on the chart, witness that. Weigh the patient before and after the procedure, because you want to know if they lost weight. They should lose weight because usually they take off a large amount of fluid. You want the patient to void before, and that is to prevent the bladder from getting punctured. You want to put the patient supine with the head of bed elevated. That's the positioning for this procedure. And then you want to remember the sequence of post-procedural vital signs. What you're looking for is hypovolemic shock because you just took a lot of fluid off the patient, right? So look for tachycardia, thirst, hypotension, dizziness, parlor diaphoresis. And if the patient does show signs of hypovolemic shock, and it is, sometimes there's not a drainage bag, okay? So the provider will just go in and pull off the fluid and put a Band-Aid over the needle site, right? But sometimes they do put in a drain, so the patient might eventually be able to go home with the drain if they're really end stage, like hospice stage, and then that way they can relieve it themselves at home by putting the drainage bag down and undoing the clamp, okay? Monitor for peritonitis, so remember fever, high white count, guarding, abdominal pain, and rigid abdomen after the procedure for 48 hours. Patients with cirrhosis are at high risk for esophageal varices bleeding. All patients with cirrhosis should be screened for varices because it's much better to try to prevent them than have to deal with them when they're bleeding. All patients with varices will be put on a non-selective beta blocker to hopefully stop the varices from bleeding. There are 2 medications that the patients can get to stop the bleeding or slow down the bleeding. One is Triatide, and that is good for every patient. And the other one is vasopressin, which you cannot give to people with cardiac issues. They will go to endoscopy, like say they come to your ED and they have bleeding varices. First thing you're going to do, make sure you suction that airway, have the suction ready to go. They're going to need endoscopy to either sclerose or ligate. That's not important. That it'll stop the bleeding. They may need a balloon tamponade, NG2, but I'm going to show you that in another slide. They'll need blood products like packed red blood cells, FFP, fresh frozen plasma, has all the clotting factors. So it's a good blood product to give in people with cirrhosis, because their blood clotting factors are going to be low as it is. And then platelets. Monitor the respiratory and the neurological system. Listen, when people have bleeding varices, the blood travels into the stomach and is digested as protein. So, when this happens, the patient is going to be at risk for portal systemic encephalopathy, because that occurs because the liver can't break down protein, or in other words, it can't detoxify ammonia in the blood. So that's what you're looking for, symptoms of portal systemic encephalopathy if patients swallowed a lot of blood, and they'll have an increased BUN. This is a picture of a Sensaken Blakemore tube. It's used as a balloon tamponade when somebody has varices. It's not used very much anymore, but it's dangerous, so I'm just going to talk about a few things. You always need to stay with your patient when you have this inflated. It can only be inflated for 12 hours. It can migrate up and occlude the airway, so you need to keep scissors in the room, okay? Because if they start to have respiratory distress, you're going to have to cut this and pull it out, okay? So that the balloon will deflate if you cut it. So just remember that. Portal hypertension also results in something called portal systemic encephalopathy. So it's hepatic encephalopathy, that's another name it's called, or PSE. And why this occurs is because, remember, the portal system takes blood from the GI system and all the nutrients and brings it back to the liver to detoxify. Well, guess what? The liver can no longer detoxify protein or break it down anymore. So what happens is it increases ammonia levels in the blood. And ammonia is neurotoxic. So your patient's going to be lethargic. They're going to have something called asteristics, and that is called liver flap. It's flapping of the wrists. They will have slurred speech. People sometimes think they're still drinking, and they're not. Early sign is reversal of a sleep-wake cycle. So they're up all night and sleep all day, and they don't work nights. Loss of concentration, like people that enjoy crossword puzzles suddenly can't enjoy them anymore. Positive Babinski's, that means when they elicit the Babinski's that the toes don't flex forward, they extend backwards. Okay, so that's a positive Babinski's. You should only see that in babies. They develop peripheral neuropathy, so they're going to have numbness and tinglings in their feet and possibly their hands, so that could be a fall risk. And fetor. Fetor breath is musky, bad breath that is caused by PSE. So it's caused by ammonia in the blood. Lactulose is a medication. It's like a syrupy liquid that is given to facilitate the excretion of ammonia and help alleviate the symptoms of portal systemic encephalopathy. So it decreases the pH of the bowel, which decreases ammonia production. The goal is to have 2 to 3 soft BMs per day, and then your symptoms should improve, like a patient that with a reversal of um, sleep-awake schedule will now sleep through the night, or somebody who had difficulty concentrating will now start to concentrate. They're, they'll be a little bit clearer in the head after this. And it's really important to monitor for signs of encephalopathy because there's like 4 different stages. And you don't need to know the different stages, but I just want to point out, like, if somebody's in stage 4, you can give them lactulose, get the ammonia level down, and they could be back in stage 2. So it's really important to monitor for those signs and get the order for lactulose if needed. One effect is from cirrhosis is the liver cannot break down hormones such as estrogen. So because of the increased estrogen in the bloodstream, people with cirrhosis can have spider angiomas, and this is a picture of a spider angioma. See how it looks like a little spider? Some people call them like burst capillaries, so that can be prevalent. The male pubic hair changes from a diamond shape to more of a triangle shape, which is more in line with the female body. They'll suffer from something called palmar erythema, and that means their palms are going to be warm and red. They're going to have impotence, males, and both males and females can have infertility, testicular atrophy. Males can have gynecomastia, and muscle wasting is common in cirrhosis, and a loss of body hair is also noted due to the effects of estrogen. Here are the expected laboratory findings for somebody with cirrhosis. So the ALT is going to be high, the AST could be high, the ALP will be high if there's biliary obstruction. The ALT and the AST will be high initially, but as the liver starts to fibrose, it no longer can produce those enzymes. So it may be just normal or low at end stage. Bilirubin's going to be high. Ammonia level will be high. That's why we give the lactulose to get that down and put them on a low protein diet. PT will be prolonged. If the PT is prolonged and the patient is bleeding, they're going to need vitamin K and FFP, fresh frozen plasma. Has all the clotting factors. You're going to give it as soon as it comes because it's frozen and there's only a short amount of time that if you don't use it, the clotting factors are going to get used up. So it needs to go in immediately when you get it. Protein is going to be low. Albumin will always be low. And it's one of the factors in ascites, the low albumin. Platelets will be low. Hemoglobin will be low. Glucose could be high or low. And WBCs will be low. In terms of nursing care with skin and hygiene, make sure you clip or file the nails because they're going to have intense pruritus and they really do scratch very deep. Put lotion on their skin. Make sure you're only using tepid water and don't use strong bacterial soap. Then pat their skin dry. Don't rub it to dry it. Use moisturizing creams. You can put cotton gloves on them to kind of prevent them from scratching themselves in long sleeves. They're going to need a soft toothbrush, and remember all the bleeding precautions because people with cirrhosis are at high risk for bleeding. So electric shaver, nothing PR, all those precautions. Okay, monitor for petechiae and ecchymosis. Patient teaching regarding the diet in cirrhosis involves if they're on a low sodium diet, you'll have to teach them about that, and that's usually prescribed if ascites is excessive. If they're on a low protein diet from PSE, you'll have to counsel them about eating low protein foods. They need soft foods if they have esophageal varices because if they eat like let's just say chips, potato chips, I just ate some, but they can be a little hard, and as they're going through the esophagus, they might bust one of those varices. So that's why they need to eat soft food. Small, frequent, well-balanced meals, vitamins, fat-soluble and B vitamins, especially thiamine. Thiamine prevents a condition called Wernicke's encephalopathy, and it's due to a lack of thiamine. And we'll talk about that a little bit more at the end of the semester when we talk about substance abuse. Fluid restriction for ascites, and no alcohol. Here's a pictorial. Spend some time looking through it and see if you remember the reasons why these patients have these signs and symptoms.